You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Nurses are the backbone of the emergency department, and we're lucky to have such dedicated, skilled, and caring nurses. We often rely on them to get things done, sometimes too much. If the nurse has trouble with an IV in a patient who is unstable, what happens? You step in and you put in an IO, right? Sometimes in adults, that means a central line, or maybe in the semi-stable adolescent, or in the difficult access adult, that means an ultrasound-guided IV. The feeling is, if a nurse can't get an IV and needs help, then we go nuclear. But do we always need to? Our skill set doesn't have to mean only the big guns. Many times, and truthfully most of the time, we just need access in the stable patient. I'll speak a little more to the heart now. In times of disaster, or when our human resources are stretched too thin, sometimes you gotta roll up your sleeves, jump in, and help out. Today, we're going to talk about the time-honored, battle-tested tips and tricks for getting that IV in. Now, I'm not going to call myself an expert at this, but I did train to put in my own IVs, and I try to keep my skills up whenever I can. There's a lot going on in the world today, and you will likely be asked to do things that you're not used to doing on a daily basis. I just talked with a group of our awesome RNs, and we had a fun discussion. We traded tips and other things we've learned over the years, and I thought I would summarize that discussion now. So first, we'll go over some universal best practices in IV placement, and then some very specific pediatric tips. Before I start, IVs are a lot like signatures. Everyone has his or her own spin or style on things. Ask 10 people and you'll get 12 different answers. So just don't listen to what we have to say here. Use these tips to add to your repertoire or modify it. All right, let's get started with our top 10 tips. Number 1, set the stage. Stay calm and exude confidence. This is the fake it till you make it approach. You gotta keep the room calm. Parents, children, and other staff will hang in there with you if they see that you have a plan. Be prepared, get everything and everyone you may need, and once you're prepped, take your sweet little time. Rushing will always bite you. Number 2, choose the right cannula size. Even in a child that needs fluid resuscitation, a smaller gauge IV is better than none at all. Go for what you know will work, not for what you're being peer pressured into. If you need more access later, that's okay. Life-saving meds and fluids can pass through that 24 or 22 gauge as well. Number 3, feeling is better than looking. When you're trying to assess the best vein to use, of course, you're going to start distally in case you blow a vein, and then you can go more proximally. Your best bets are in this order. First, the vein that you can feel and see. Next, the vein that you can feel only. That's right, you have to trust yourself on this one. And finally, the vein that you can only see but can't feel. Your eyes can fool you here. If you're feeling particularly nerdy, you can look up the Tyndall effect. It has to do with light scattering in liquid. Feeling is better than looking. Number 4, mark the site. So you have a good vein. You feel it. Mark it with the end of the IV cap. Take the blunt cap and press it into the skin for a few seconds, gently. It'll leave a little temporary mark that you can't wipe away when you use your alcohol or chlorhexidine to prep the site. Again, your eyes can fool you, and your fingers can dirty up the puncture site. It's so much easier having a little target to work with. Number 5. Tourniquets can mess you up. Don't get me wrong, sometimes we have to use them, but they can over-engorge a vein. When you go to puncture it with a needle, the vein may then blow. So it's a balancing act. A problem I see is when someone starts the search for an IV with a vein and they have their tourniquet, they leave it on, and they keep it on for the entirety of the process. It can be painful to patients, and unknowingly, it can sabotage your efforts. One option in older children and adults is a manual blood pressure cuff at the arm far away from where you're inserting the cannula. Now, having said that, think of the traditional tourniquet as something to be used as sparingly and as briefly as possible. Remember, once you get that flash, you're taking off the tourniquet, or the vein might blow. Number 6. The holder is king or queen. In children, you need a buddy. Sometimes more than one buddy. Real talk, toddlers can exhibit superhuman strength. They can make a wild PCP overdose look like a warm-up stretch. Having someone hold and stabilize the child's shoulder girdle allows you to hold and adjust the whole upper extremity as you need to. A good holder or set of holders can make or break your efforts. Speaking of holders and tourniquets, the best practice is to have your holder use one hand to stabilize the shoulder and the other hand to wrap around the child's proximal forearm. Your holder is your tourniquet now. The nice thing about this is that the holder's hand has a wider footprint, a larger surface area to apply pressure, so less likely to cause focal pressure and less vein blowing. Also, it's a dynamic tourniquet. You can communicate with your holder to release or add pressure as you need. Number 7. Tension is good. You want to feel the fine balance between holding the skin gently secured, which is what you want, and pressing down the vein, which is what you don't want. You'll use your dominant hand to place the cannula, but you can use your non-dominant hand to readjust the arm as needed in communication with your holder, and use that non-dominant thumb to hold the skin as counter-traction for when you pierce it with the needle. You want to decrease the friction that may be created with the needle clumsily going through puffed up skin and subcutaneous and fat and more, just to finally reach that vein. Each of those tissues has a different resistance, and that can help you to undershoot or overshoot. Tension helps to fix that vein in place, but it also decreases the chance that you'll get caught up in one of those layers. A little tension, pulling the skin gently towards you as you pierce with the skin away from you, will help you pass the needle like butter. Number 8, stay in line. When you're wrangling a small child, or frankly trying to avoid getting slapped by an adult, it's very easy to get yourself into weird contorted positions when you're trying to cannulate. Your needle is an extension of your arm. Stay in line with the needle and your needle in line with your vein target. If you try to go in from some weird side angle because the gurney is in the way or the teddy bear is in the way or whatever, you will surreptitiously sabotage yourself. Stay in line with your target, face the forearm, be confident, and you'll get it. Number 9, gravity is your friend. You can have the upper extremity dangle over the edge of the gurney. This way, you can control the forearm better since you can wedge it gently against the mattress cushion, but more importantly, you'll have the safest tourniquet ever. And it's organic and pasture-raised. It's gravity. The veins will more likely engorge, but they won't blow. Number 10, the 3 F's. Flash, flat, and forward. You can have all the prep work, the best holder, gravity is your friend, you are in line, all is looking great to move forward, but you still can't get the stick. This is probably the most common way to lose your IV. So this way: flash, flat, and forward. This is your goal with inserting the needle over the catheter. Recall that the needle is about 1 to 2 millimeters longer than the catheter. You're going to use the bevel up. You're going to pierce the skin at a 15 to 30 degree angle. The fluffier the patient, the steeper the angle that you need to start with, and vice versa. Areas with little adipose tissue don't really need a steep angle. So 15 to 30 degree angle, you pierce, and you get a flash. Right now, only the tip of the metal needle is what's in the vein now, not the plastic cannula yet. If you go forward at that same 30 degree angle, you will pierce the opposite wall of the vein and you're going to miss it. So, as soon as you get that flash, you'll want to flatten your angle. Drop the angle of your approach so that the IV is as flush to the skin without rubbing against it. Now is the time to release the tourniquet. If you advance the catheter against an engorged vein, again, it might blow. So you've got the flash, you've gone flat, and now you're going to go forward. You still only have that needle tip in the vein. So with your improved angle, you can advance the needle just another millimeter, no further. You should see what's called a second flashback. Now you'll have continuous flow. Then you can gently but decidedly push the catheter only forward. The needle and IV apparatus stays stationary while the plastic catheter is directed forward into the vein. Since you've aligned the vein with the angle of advancement, keeping tension, all of those tips we talked about, the plastic catheter will be able to move forward into and along the inside of the vein without resistance. This is the finesse part of the procedure and the most stressful. So your calming mantra is flash, flat, then forward. What we've talked about so far really applies to most age ranges, give or take. Let's talk about a few pediatric specific tips. First, find a good site. Remember, feeling is better than looking wherever that may be, but here are a few sites you can try. The dorsal metacarpal veins on the back of the hand. They're superficial, they're palpable, and they're visible. You can easily hold and control the hand, and it's the most distal site in the upper extremity. And as we know, if you blow the veins there, you can always go more proximally. The cephalic vein is usually pretty prominent and can be found at the level of the wrist, just proximal to the thumb. It's called the intern's vein or the nurse's vein because it's pretty reliably present and superficial. The basilic vein is its counterpart on the ulnar side of the wrist. The basilic is deeper and smaller at the wrist, so it's probably best for older children. The antecubital veins are the conjunction of the basilic and cephalic veins. The upside of these veins is that they're usually pretty reliable. They're usually just there and almost always palpable. The downside is that you have to keep the elbow extended, and they're really only meant as a temporary access. We use them a lot in the ED because they're easy targets, but upstairs after admission, they'll likely be changed out. Well, what about the lower extremity? You can use the great saphenous vein. Find the medial malleolus and feel just anterior and proximal. You can feel this vein, but not always see it. It's a large vein that is almost always tented full, tented open, because of gravity and the supporting structures around it. By the way, it's also a great cut-down vein as well, but more on that on another episode. Bear in mind that anyone that you expect to ambulate won't do well with a lower extremity IV, but then again, if you're looking there, you've probably exhausted other options and the patient is sick enough to need a lower extremity IV. And finally, what about the scalp? In small infants, IV access can be tough. If the infant is sick, just use your IO. But If you need blood or you just want to start an IV in a relatively stable, small infant, you can place a rubber band snugly around the head just above the ears. You'll see a few frontal veins pop up, or veins on either side of the ear. So the superficial temporal vein and the posterior auricular vein. You can cannulate those with a small IV, or you can always use a small butterfly needle. The advantage, of course, of the IV is that it can be secured and used for a few days. The downside is that it's hard to pass even a small IV cannula in those tiny little veins. The butterfly needle's advantage is that the small needle very easily accesses the engorged vein, but then you'll have to leave the metal needle in it and secure it, so it's really only meant as temporary access. Now that we have a few options for the sites in the little patient, here are a few procedural tips. First, optimize the site. Heat packs work very well here. Heat is a venodilator. The warmth also helps with the gate theory of pain. The heat modality takes up some of the afferent nerve signal, diluting the pain signal. Speaking of which, some people swear by EMLA, the eutectic mixture of local anesthetics. It's very helpful in thin skin to anesthetize, but it also vasoconstricts. The other downside is that it takes about 30 to 45 minutes for EMLA to have its full effect. In select cases, it may be well worth it. It's excellent for a planned admission or for a child who has a portacath site, so the subcutaneous implanted reservoir used for chemotherapy or other infusions. Like anything, there are trade-offs. Just know what you have, what your goals are, and you can choose your best option. Even sometimes in very skittish adults, if we have time, I'll use EMLA knowing that their skin is probably a little too thick for it to be of use, but anything might help them, and, we do what we can. Speaking of local anesthetics, the J-tip, or the needleless skin injector of local anesthetics, it's a good choice too, but it's loud, and we can really spook the young child. In older children, you can use guided imagery. So, oh wow, your skin looks so thirsty. I think it needs a soda, or pop, or whatever you call Coca-Cola. And pop! Do it right away. No suspense when you're doing something on an awake child. Let's talk about securing the IV. Again, there are all kinds of signature ways of doing this. We'll start with the principles that everyone will agree with: security, access, and safety. First, let's secure the IV. You've pierced the skin, gotten the flash, went nice and flat, and advanced forward. Just before you take the needle out, use your other thumb to press down just proximal to where you imagine the end of the catheter is. This will help slow the flow of blood and prevent you from being an adorable but very messy IV starter. It can get really bloody if you don't control things. With your thumb holding proximal pressure, you can use your dominant hand now to screw in the saline lock that you've already primed. Great. Now you can take both hands off, but not for long, since the catheter is in, but it's very vulnerable. You have to secure it. Use a piece of tape to create a chevron that goes between the IV hub and the skin and folds up and over and flanks each side of the catheter hub. Then another horizontal piece of tape simply over the hub. Now, before you get too crazy with more tape, secure the child's hand and wrist to a nice IV board. You can make one out of any material, but my advice is to make sure the whole palm and fingers sit flat on that board. Tape the fingers just distal to the metacarpal joints and again at the wrist. Once you've secured your wrist board to your liking, you can work on taping the IV tubing loop. By securing the IV board first, you can allow better access to the loop in case you need to change it out or connect something else to the IV. Loop it conveniently using your best common sense and make sure those loops get tacked down as well. So it goes: secure the catheter first with chevron and horizontal tapes, then the handboard, and then you can tape down everything else. Once it's all secured, make sure that you wrap that whole beautiful bundle in something, anything, Curlex gauze wrap or a diaper or a towel, and make sure that the child can't see it. The little child will not fiddle with an IV if it's out of sight. Now you have the double secret ninja knowledge to become one with the IV. Here are a few miscellaneous things that we should mention. The vein locator. Some people swear by it, some don't like it. Remember, feeling is better than looking, but if you can't feel and you can't see, then a ghost image of the general area is better than nothing. Just remember that light scatters in liquid. The vein locator is meant to give you a general location. It's not fluoroscopy and it's not ultrasound guidance. In adolescents and adults, you can put a small amount of nitroglycerin ointment on a small vein. Wait 2 to 3 minutes, wipe it off completely, mark your site with the blunt end of a cap, and disinfect. Now, make sure that you do not use nitroglycerin in small children. The topical nitro can be absorbed, and children have profound hypotension with systemic nitroglycerin, which is one of the reasons we don't use it for baby CHF. A few tricks for patients with darker skin tones. Wipe the alcohol swab in the direction of the target vein. The liquid catches the ambient light and can give you better contours. If that doesn't help, we talked about avoiding tourniquets, but sometimes you need them. You can use a manual blood pressure cuff more proximally to gently distend the veins distally. This should be far enough away from the target vein to decrease the risk of blowing that vein. Don't slap, flick. That is, slapping that vein may make you feel like you're doing something, but it can be painful, especially with the tourniquet on. It's jarring and it's just dumb. Flick it instead, gently. Gentle flicking or tapping is thought to release local histamines and cause venodilation. Try floating the catheter. So you get that flash, you flatten that angle, you release the tourniquet, and you start to advance. You feel like you're doing everything right, you advance forward, and blood stops flowing. You feel that you're in, but you're just unsure. You can attach tubing primed and connected to a syringe. Gently, gently, gently push a tiny flush. You may be up against a valve, and that micro flush may push the tip of the catheter out of a recess in the valve. If you see extravasation or if you cause pain, then for sure you're out of the vein. Which brings me to infiltration. You may have pain or swelling at the site or difficulty administering pushes. Or even later after placement, the IV drip becomes inconsistent. Occlude the vein proximal to the IV site. If the IV drip stops, you're good. You're still in that vein. If the IV drip keeps going, you're not in the vein, my friend. Assume infiltration and take it out immediately. Elevate that extremity and apply a cold compress. If you gave any caustic meds through that IV, look up the sequela and observe carefully. And finally, don't let the failures of yesterday prevent the successes of today. We all miss veins. It's inevitable, especially if it's been a while. Let it be a lesson and go forward. The more you do, the better you are. When you got it, and now you're in it to win it. A quick summary, our top 10 tips and tricks. Number 1, set the stage. Exude confidence and be prepared. Number 2, choose the right cannula size. A smaller working IV is infinitely better than none at all. 3, feeling is better than looking. Trust yourself. 4, Mark the site. Things get wonky when you take your hands off to disinfect. 5. Tourniquets can mess you up. Try to use a holder's hand to occlude the vein, but sometimes you gotta go for it. Just know that the trade-off is an increased risk of blowing it. If you use a tourniquet, take it down before you advance that catheter. 6. The holder rules. Get as many hands on deck as you need. 7. Tension is good. No, not the dramatic kind. A little counter traction on the skin with your non-dominant hand helps to decrease the friction as the needle goes through the fascial layers. Number 8. Stay in line. No weird angles, fam. Number 9. Gravity is your friend. It's the kinder, gentler tourniquet. And finally, 10. The 3 F's. Flash, flatten, and forward. Get the flash at a 30-degree angle. Flatten that angle as you flush if you need to, and DC the tourniquet if you're using it. Twist that beautiful little plastic catheter over the needle forward. Thank you for listening. Try these out and let me know your own tips and tricks. And until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.